Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Welcome to Central Line. I'm Keya Lock, your host. Today I have Drs. Julie Ma and Moeed Azam with me to discuss practice management staffing models. Drs. Ma and Azam are the guest editors of July's ASA Monitor, and I've been looking forward to this discussion. So welcome to the show.
Thanks for having us.
So before we get to the topic, can you both share a quick bio with our listeners so they can learn a little bit more about you and your work before we jump in?
Sure, I can get us kicked off. First of all, thanks for having us on this podcast today. Really excited for the conversation, the discussions ahead. A little bit of bio about myself. Clinically, I did my anesthesiology training at Emory. Afterwards, I stayed on as a faculty anesthesiologist. Administratively, I am the medical director of peri-op services here, and I'm also the chief of clinical operations for the Department of Anesthesiology. Been actively involved with several ASA committees, most notably and most relevant for this one would be practice management. And really excited for what's ahead here.
Great. And Mo, Azam, in Orlando, Florida, I get to work alongside with Dr. Lock here, our host in the Florida Society of Anesthesiologists. Worn a few different hats, legislative affairs on that side. With my practice, clinically, I had led liver transplant anesthesia for a number of years, served on our local and national quality committees. And for the last few years, I've been the head of innovation for our practice. Nationally, getting to do lots of cool things with AI, tech initiatives, and some workforce related stuff like partnerships for academics, training, and the business of anesthesia.
Thank you so much. I'm really excited to talk about this. So let's start with the business of medicine. We all work so hard to become clinically proficient, but how important is it for anesthesiologists to understand the business side of medicine as well? And to Dr. Ma, if you could just start us off by telling our listeners why that actually matters.
Sure. Clinical excellence and patient care will always remain core pillars of what we do. To your point, we spend years, decades training for that. But at the same time, I think, in today's healthcare landscape, that itself it's just insufficient. Many of the challenges, that we face today as anesthesiologists, they're not just clinical problems anymore. They're a combination of financial issues, strategic problems, and operational issues. And these decisions are going to be made with or without us. I think understanding the business of medicine really allows anesthesiologists to move from a reactive position to a proactive leadership role. And I think it's important to point out that, when I refer to business literacy and understanding of the finances, it doesn't mean that every anesthesiologist actually needs to go and get an advanced business degree or even have interest in being a future hospital executive. What it does mean, though, is by understanding the fundamentals of the healthcare business and finances, we can better advocate for our patients, we can better advocate for our specialty, and we can better advocate for ourselves.
Thank you so much for that, Dr. Ma. And just building on that, you suggest in your editorial that anesthesiologists should be in leadership positions. So can you talk to us a little bit more about why it's important to have anesthesiologists at the forefront to impact practice management issues?
Sure. I actually take a pretty strong stance on this. And I think it's not just that we should, but rather we must participate in leadership. I think we as anesthesiologists are in a unique position to be healthcare leaders. Our work, our perspectives, and our impact really extend beyond just the operating room. Every day we work at this intersection of surgery, nursing, critical care, procedural services, and we see very much in real time how the decisions that are made in one part of the system go on to affect the rest of that patient's journey. And I think that's a super powerful position and a really unique vantage point to hold. And when we talk about practice management issues, these are fundamentally system problems. They're not just an individual anesthesiology or an individual group issue. And we as anesthesiologists are trained to think in a systems-based and very data-driven approach. Every single day, we're constantly integrating information, managing resources, figuring out risk-benefit analysis, and we're making these real difficult decisions in a very complex and stressful environment. And my thought and my takeaway on this is that we as anesthesiologists, we're not just working in one clinic or one hospital unit. We see the entire perioperative space. We see how the system, the healthcare system works at large. And I think that systems approach and perspective is what's needed today in healthcare leadership.
Thank you so much for that, Dr. Ma. You really paint a picture of anesthesiologists as perioperative experts, essentially, with our, ability to sort of think in that systems type model. But now let's talk about the challenges that we're facing. And more specifically, Dr. Azam, can you talk to us a little bit about how adaptive staffing models can be used to deliver improved and efficient care?
Thanks for the question. I don't know any challenges we're facing right now. Just kidding. Obviously, everyone's been talking about some of these things, right? At ASA Advance, certainly it dominates a lot of our conversations. Workforce, staffing, coverage, reimbursement, model shifting to losing autonomy in our space as leaders of our professions, of our practices, and coming from a variety of different directions, payer, corporate, even university folks feeling the various pressures coming in from their deans and their academic departments. This series of articles was originally around staffing, and I think Dr. Ma really was able to have some creativity in pivoting. Let's talk about workforce in general. We're being asked to cover more and more than we've ever covered before. And I might say, and I've had this presentation before at ASA Advance, that I'm not really sure, and I'm willing to do a pro-con debate on this, that I'm not really sure it's an issue about our ability to train enough folks. We have more folks in training than we've ever had before. We have more CRNAs and CAAs than we've ever had before. And the issue is really demand as opposed to supply. And so the demand has really outstripped our capacity because we're covering things that we didn't cover before 15, 20 years ago. 23 years ago when I started in practice, we were hardly in the GI area, a little bit, only for the complicated stuff. We were never in the cath lab. We didn't cover any interventional radiology, the rare occasional MRI or something like that on kids. And today in my practice locally, I think we've probably got 20 to 30 rooms of those services going on every day, and many rooms of that happening every day on the weekend as well. So that was the point of this set of articles, and for us to start to think about with our various authors, the different approaches to these coverage issues. How do we get creative with an FTE? How do you allow folks some flexibility early in their career, mid-career, late in their career to basically increase capacity? How do you solve for what the market has shifted? And by the market, I mean the labor market, where folks maybe aren't as apt to wanting to do 14-hour days and work 70, 80-hour weeks. For a variety of reasons. It's not that the income has gone down. It's that maybe the satisfaction or the friction when you're actually there at work has gone up so much. So to answer your question, adaptive staffing models is one of the points of the articles in our series, and the creativity around staffing and to be able to give folks flexibility actually produces a net positive FTEs. And I think some of your follow-up questions hopefully can address some of those things on gender, aging, different parts of the workforce.
Absolutely. And as you so clearly articulated, NORA is expanding, which adds pressure to our workforce issues. Are there solutions that can help that you can talk with us about?
NORA is an interesting environment. It's probably more appropriate or leans towards care team coverage for a variety of reasons. Sometimes just the geographic spacing, the ability to be able to see the next patient coming down for interventional radiology, because they're not quite like our regular pre-op bays, right? Where you can see a bunch of folks in advance. They're sometimes coming down right in time for the procedure. They're usually complicated, inpatient, lots of stuff to review in the chart. Really takes the anesthesiologist and puts them at the leadership of that team, because you don't have a surgeon that has done an H&P there. You've got interventionalist who's more of just focused on the procedure. They may not have even assessed the patient medically. Their team members might have. So that falls on us. So that's one aspect of the NORA coverage. The other aspect is, maybe those days don't run as long. So maybe these are good places for some of that flexible workforce, as we've all probably gotten much more flexible with shifts, 7 to 3, 3 to 7. And you have got different shifts of your care team or your clinicians, even some of the physicians. Maybe these are places that allow them a little bit more predictability in their schedules and a different lifestyle overall with their hours.
Right. And then also let's pivot a little bit. Do you feel that gender inequalities are still a problem? And if you do, can you talk with us a little bit about why inequities sort of threaten the long-term sustainability of our specialty?
A great article was submitted for this, Dr. Levy and a few colleagues of hers, and they actually quantified the economic impact. And I think that's a great lens, as Dr. Mao said here, about the business of anesthesia. So take away any political aspects or people's slants or biases one way or another. Let's just talk about hardcore business. And I think in her article, she really points out that there's about $1 million net impact to women in the workforce and in the anesthesia side. And the economic cost of needing to recruit or replace an individual in the workforce is about 3x their salary, 2 to 3x their salary. So that's $1 million to the anesthesia practice. It's $1 million to the clinician. That's bad for business all around. So how do you solve that issue in a way that helps both sides out? Creativity and flexibility at the right points in their career. And that applies, forget about gender, it applies to even other sides of this. One of our colleagues on the committee said, well, they were adopting a child. And how does that impact, someone right around their mid-career when that life event is occurring? We've had a few folks in my practice that continued to stay to work in their 60s, mid and late 60s, when they were offered flexibility in staffing, in per diem, in splitting a partnership with another colleague, 1 for 2, 2 for 3. And so I think these solutions alleviate a lot of the challenges, and you take gender, age, life events, and now you create a net impact that's positive for the practice and for the individual.
That's really well said. And looking at all those pieces, as you said, and sort of creating this net, this is what we've got. And we're looking to the future. And I'm sure not only me or not only you, everyone is asking themselves sort of what's coming and are we ready? And if we're not ready, how do we even begin to prepare ourselves?
Yeah, it's a great question. It's a tough question. It's going to be very much a sort of looking at crystal ball exercise. I think there's certain things we know are likely going to happen, but there's also a host of things we simply just don't know. I do think that the future of anesthesiology and healthcare is going to be defined by continuous growth in demand. To Dr. Azam's earlier point, the NORA explosion has been ongoing and it's continuing to explode. I think the complexity is going to continue to increase, and the workforce constraints that we've been talking about, those aren't going away anytime soon. I think the question we really need to ask ourselves as leaders in healthcare and anesthesiology is really, are our staffing models, our leadership structures, and our overall strategies keeping pace and being proactive in meeting the changing healthcare landscape? I think technology will definitely be a big, huge part of that. AI is got all the hot buzz right now, and for the right reasons. I don't see AI tools and advanced analytics in themselves replacing any anesthesiologists in the immediate future. But I do think we'd be remiss to dismiss the importance of AI, because they absolutely can help us work better and be more productive. So how do we prepare for the unknown? How do we prepare for the future? I think the core principles is that we need to invest in our people first, right? We need to support their development, meet their needs, meet their demands. And along with some of the other topics that have been brought up already, we need to take a data-driven approach to adaptive staffing. We need to align our resources and our workforces with what the overall hospital goals are, the overall perioperative services goals are. And if we can stay in line, we can be much more effective.
Thank you for that. And you both sort of pointed out, in my mind, what sounds to be the big things, that we are going to be exactly that, which is adaptive as we move into the future. So thank you so much. And just, turning our focus a little bit back towards the leadership vein, for our listeners who want to sharpen their leadership skills, can you share advice on resources that could be of help?
The American Society of Anesthesiologists has partnered recently with an organization to help support and provide some of education and leadership development. It's the American Association for Physician Leadership, AAPL. They have been working together, including at our annual and advanced meetings, to provide additional training and a lot of coursework. To be honest, I think, leadership is one of those things that really requires very practical, hands-on role play activities where you can go through workshops and mentorship, which is great because the assets available from AAPL and our association can provide some of that executive coaching and additional support, and just getting on the ground, volunteering for participation, whether it's your P&T committee, your hospital med staff, your department meetings, and allowing a mentor in your practice to let you run one of those meetings, coaching and side by side. How do you start that meeting? How do you bring up a difficult topic? How do you allow folks in the room to voice their opinions and then help try to get to a consensus? And some of those things are very, very practical.
Absolutely. Thank you both so much. And before I let you go, can one or both of you share a little bit about your experience on this issue? Sort of, did you learn anything that made you think differently about staffing models in general?
And truthfully, I can say that I actually learned something from every one of the feature articles. I think there's a ton of wonderful information in the 5 feature articles in this upcoming issue. I think one of the big light bulb moments, or one of the biggest insights for me, is realizing that our anesthesia workforce and staffing models really need to be evaluated more broadly as part of the overall system strategy. I think day to day, we really focus on schedules, staffing vacancies, coverage gaps. And those are obviously super important because we need to keep the ORs running. We need to keep the train on the tracks. But to me, staffing models is really an expression of what the organization's workforce strategy is, right? So if we're consistently seeing delays, increasing labor costs, coverage gaps, we put them in the bucket of staffing problems because they are staffing problems, but they're also signs that the staffing model that we're using is not matching what the organization's needs are, right? We're not meeting the operational demands, and we're likely in that situation not meeting what the workforce actually needs. So I think to me, the biggest takeaway and lesson from all the articles in this issue as a whole is that anesthesia workforce capabilities drives all the other things around it. And, we have to invest in building a resilient, engaged team. And when we do that, and we've got the right people in the right places performing at a high level, the operational performance, the patient, physician experience, and the financial performances typically follows suit. I think it's just really important to take a more overall strategic approach to thinking about how we staff, rather than just simply thinking about how do we fix or how do we fill the next gap in endoscopy or the next gap in radiology.
Absolutely. Dr. Azam, did you have anything you wanted to add to that as well? I couldn't agree more.
That's fantastic. And I think having this lens of approaching this from business solutions and a great framework, one of the articles lays out very well the financial aspects of this, economics, costs of labor, level setting that subsidy or support requirements for under reimbursed uncovered services, the way that impacts customer access and experience, customers, surgeons, patients, and consistency across the sites, your internal processes and your practice or your department to provide predictability, efficient room management, and how all of the things that you do as a business, as a practice, as a department can support that, and recruiting, onboarding, compensation alignment, and long-term workforce planning. I think all of that's great. It's the business of anesthesia, and it's something that we should be absolutely leading on.
Absolutely. It's almost, it reminds me of that quote. It talks about, once you've appropriately defined the problem, then you're halfway to the answer. And so I think Dr. Ma alluded to that, just looking at things sort of from a systems issue and not just so it's a staffing problem, figuring out exactly what the problem is so that we can start coming up with creative solutions. So I really thank you both for that. I'm certainly looking forward to reading this issue. So yes, thank you very much. This was a great conversation. Thanks to you both for joining us. Listeners who want to learn more can visit asamonitor.org for more information and come back soon for more Central Line.
From day-to-day practice administration and revenue cycle management to leadership, quality, patient safety, and beyond, ASA Advance, the anesthesia business event, is your opportunity to build a stronger, more sustainable practice. Join clinicians, practice leaders, healthcare economics experts, and more for practical insights and collaborative learning on all things business each January. Learn more at asahq.org/advance. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.